Good evening, everyone. I'm Jeff Badnock, and on behalf of the Alumni Association Community Lecture Series Committee, this is going to move. Well, I'll just keep ducking down. I'd like to welcome you to the second of this year's lecture series. And this year, our series is on health in the new millennium. And I'd like to acknowledge the committee that's worked to put this together. Ann Boone, Kitty Robbins, Don Hobby, Chris Comer, and Linda Gillison. And this year we've been assisted by Reed Humphrey, the gentleman who gave our lecture last week, and Brent Ruby. All the lectures that we do follow a simple idea, and that is to showcase to the community the wonderful, marvelous, interesting things that are going on at the University of Montana. And this year is no exception. I would be remiss if I didn't do what Linda always does. Please silence your phones. That's first thing. At the conclusion of the lecture this evening, as always, we will have microphones available around the venue for you to ask questions. So as you hear the lecture tonight, be thinking of questions you want to ask the speaker. That's part of how this works. It's why this works. It's an engagement between you and the audience and our speaker. The University of Montana health medicine idea has taken a big leap forward recently. I just read today that President Sheila Stearns has pitched the idea to the Board of Regents to create, see if I get this right, a Center for Translational Medicine here at the University of Montana. And all the ideas that Reed Humphrey talked to us about last week about integrating these different disciplines and how University of Montana is doing it differently than anywhere else, that's now in the hands of the Board of Regents to see if we can make that an actual program here at the university. By way of introduction of tonight's lecture, our lecturer is Dr. Anisa Goforth. She's an assistant professor of psychology and the director of the School of Psychology's graduate training program. She got her BA at Lewis and Clark College in Portland and did her master's and doctoral work at Michigan State University. And her work emphasizes the principal focus is on school psychology. So tonight's lecture is entitled Autism, Signs, Symptoms, and Strategies. Please join me in welcoming Anisa Goforth.
Thank you. Hello. Hi, everyone. Happy Valentine's Day. I'm impressed that you are here, and for you couples, I can't imagine this being the best date that you could ever have on Valentine's Day. And for the single folk, maybe you can huddle over here afterwards and you can see who's single amongst the group. But thank you. This is really an honor to be invited here to talk about some research that I'm really passionate about. So let me tell you a little bit about myself and how I'm going to present this today. So my research is actually focused on culturally responsive interventions for children who are culturally and linguistically diverse. So I actually have a specialty on working with Muslim youth and Arab American youth. So then you're like, why is she presenting on autism? So the reason I started getting interested in autism is because I'm really interested in social skills. So think about the time if you've traveled, you were in a completely foreign country, and you messed up a little bit on the cultural norms. Like maybe you used a fork when you're supposed to use a hand, maybe you dressed in shorts when you're supposed to wear, pants, you were wearing shoes inside the house when you're supposed to take them off. Well, fortunately, that's social skills, right? Your ability to interact with people, to meet and greet a person and say hello and look them in the eye, or not look them in the eye, depending if they're an elder or not. So my interest in autism, in fact, I was kind of like, no, I'm not interested in autism, not really interested in that kind of research. And then I collaborated with the Department of Communicative Sciences and Disorders in realizing that there's not a lot of services here in Missoula and frankly the entire state of Montana for kids with autism spectrum disorders. And through my work with my colleague Jennifer Schofer-Clausen and the Communicative Science and Disorders, we started collaborating and really conducting some really interesting research focusing on social skills. And so we have a treatment program here in the university, and so I'm going to talk about that at the end of this presentation, and then introduce a little bit what we mean and how we define autism. Now, this is kind of a introduction to autism spectrum disorders, so I want to make sure there's plenty of time for questions, and hopefully this will have just a glimpse into what a wonderful group of kids, and I'm focusing on kids particularly today, who have autism. And I'm going to start with a story. So her name is Emily. She's not a real child. She's kind of a conglomerate of clients I've had, my experiences in clinics. So she is 4 years old, and when she was about 3 years old, she was diagnosed with autism spectrum disorder. Her parents, around 18 months, just noticed that she wasn't talking like her siblings. She also didn't make a lot of eye contact with her parents. Even when they called her name, Emily, Emily, she wouldn't look at them in the eye. And they became concerned. They said, she's not reaching these developmental milestones that we know kids at age 18 months, 3 years old, 4 years old should have. And she also had some interesting odd behaviors. She held a red Lego in her left hand and a blue Lego in her right hand, and she would twirl. And she would twirl and twirl the Legos over and over and over until something eventually took the Legos away. She also had some strange language skills. She would often skip S's. She was able to speak some very short phrases, but certainly not what you would expect for a child at 4 years old. So with a girl like Emily, what I'm going to do is walk through how we might determine whether Emily has autism spectrum disorder. So I'm going to go an overview of what autism is, talk a little bit about some causes and what doesn't cause autism as well, and then talk a little about just generally some interventions that we know are research focused, and then introduce a little bit of what I do here at the University of Montana. And I'm going to start with this pattern. To really understand the early signs of autism, we have to recognize that we can't just necessarily use a label. That in fact, each child has his or her individual needs and individual symptoms. The joke that we say among psychologists and mental health providers who work with autism is one child with autism is one child with autism. There is a variety of different symptoms of what a child with autism looks like. But generally speaking, what we know is that autism spectrum disorder is a developmental disability that impacts a child's social and communication skills. But we have to understand these symptoms can look very differently. So in this example here, I have a tartan. Each tartan has a different color, different shapes of patterns of lines. Some are thicker, some are thinner. Some of them overlap, some of them don't. But yet we all know that this is a category that we can call a tartan. And this is how we can think of autism spectrum disorders. So for children like Emily, she has a set of behaviors. We know, for example, the Lego twirling is very specific to her. But would I find another child with autism with a Lego, red and blue, and know that means autism? Not necessarily, right? That is a very idiosyncratic symptom for her, for Emily. But generally, we know we have a category of autism spectrum disorders. And what started this category of autism is about 60 years ago, A researcher named Leo Kanner first termed the word early infantile autism. And he was describing 11 children who showed some difficulty with relating to other people. These children had difficulty adjusting to new situations. They had difficulty with routines. So if a routine was broken, like something happened where the routine wasn't occurring, then the child would tantrum, melt down. A little bit before him, Hans Asperger gave a lecture describing this group of children with very kind of idiosyncratic behaviors, so very specific to those kids. They had difficulty approaching others and engaging. They had trouble displaying emotions. And what this led to was this category that we now call autism spectrum disorder. But it's also been called autistic disorder, Asperger syndrome, high-functioning autism, atypical autism, pervasive developmental disorder. Those are all terms that we kind of clump under this category called autism spectrum disorder. And there's really some key characteristics. And the best way that I can describe these symptoms is by showing you video. So bear with me. So I have to go from my PowerPoint to a video, So, but I think it really highlights some key symptoms, and I think it'll be interesting for you to kind of think about how diverse this group of children are. But there's really kind of 5 things that we're looking for. First is a deficits in social communication and social interaction across multiple contexts. So if any of you have been at a party, you're having your drinks, and you're trying to avoid any conversation with anybody. It's just like, I just don't want to do that. You know, it's just like, it's uncomfortable. So that might be typical, right? Because all of us might be comfortable in some social situations and not comfortable in others. For children with autism and adolescents with autism, it's across multiple contexts, really difficulty with social communication. We also look at restricted, repetitive patterns of behavior, interests, or activities. So my favorite story is I had, he was a little boy, he was about 6 years old at the time. And he knew everything about dinosaurs, which for every 6-year-old boy, dinosaurs are awesome. So it's not that atypical, but he knew the differences between the kinds of dinosaurs, what era those dinosaurs were in, when dinosaurs changed from era to era, knew which ones were carnivorous, which ones ate veggies, and can tell you lots and lots of detail. And when you got bored after an hour of learning about dinosaurs, he would say, well, let me tell you more about dinosaurs. And even though I might turn my body away, you know, think about the last time you met someone you really didn't like, and you kind of did the little bit of movement, social cues. How about I go somewhere else and we'll just end this conversation? Well, kids like him would follow you and tell you about dinosaurs because he's really interested in dinosaurs. So I'll give you some more examples of restricted behavior and interests, but they are very specific, and that's all they want to talk about, that's all they want to do, and that's what they need to do. And then finally, they have to be present in early developmental period. So some symptoms that might come out, if there's a traumatic brain injury, sometimes some of these lack of social engagements, kind of difficulties with social interaction might come out after a TBI. However, for an autism spectrum disorder, typically we need to see that those early developmental milestones were not met. So let me give you some examples. So the first example I'm going to give you is I'm going to talk about some deficits in social communication in Jimmy and Ethan, okay? So the way that social communication and social interaction is kind of defined is like the kids are in their own world. So the 6-year-old boy who wanted to talk to me about dinosaurs, he was in his own world. He didn't understand that I think dinosaurs is somewhat interesting, maybe for 5 minutes. I didn't want to spend an hour talking about it. But he didn't understand that. He wasn't able to read my face and say, I'm done talking about dinosaurs now. In fact, by the way, that's how you stop conversations. It's time to not talk about dinosaurs, and then you move on. So I'm going to show you a video of Jimmy. And these videos come from Autism Speaks, and they have a wonderful glossary of videos. So this is actually free if you just register. So just in case you're interested in learning a little bit more and talking about some early signs, there's some great videos. So what I'm going to focus on is Jimmy here. So Jimmy is typically developing. You would expect certain things to happen as a 15-month-old. So I want you to focus on his engagement with his mom. Focus on the eyes, focus on where he's looking, focus on his expression, okay?
Pop. Hello. Oh! No way. One more? Oh, you got it. Very nice. Well, there you go. They're for you. Bubbles. Bubbles. Let Mama open. You give it to Mama? Give it to Mama. Yeah. You want me to blow bubbles?
Okay, so in Jimmy, he really wants more bubbles. So he can't quite verbalize yet, it's typical for his age, but he's learned that if he looks at mom, looks at bubble, looks at mom, hands bubble, bubbles happen, right? In fact, that's what we call joint attention. That's how we figure out we're engaging together, right? So we know that joint attention in particular is one of the symptoms we see children with autism not have. They have difficulty. If I said, hey everybody, look over there, you probably would look at me, look at my hand, and find out where I'm pointing. But for kids with autism, that is very difficult, to the point that oftentimes they can't do it at all. What I want you to look at is Ethan, and look at the way his behavior is.
Uh-oh, only got one. You got it. You got it. There's the bubbles. There's the bubbles. Do you want more? Do you want more bubbles? Ethan. You want more? Can you give him? Ethan. Says if I keep rolling them, maybe somebody will take them. Can you give them to Mama? Give it to me, sweetie. Give it to me. Let's give them to Mama. Give them to Mama. Thank you.
Okay. Do you see the difference there between Jim and Ethan? Ethan hasn't learned that if you look at someone's face, that actually communicates something, right? You can see that if you want bubbles, in fact, I don't think he was not interested in bubbles, or didn't really, actually he was more interested in rolling, right? So that might be described as a repetitive interest, the rolling of the bubble container over and over and over. He was more interested in that. So that is related to social engagement. I want to show you how another aspect of symptoms. So here we have Hannah and Ryan. So Hannah is 4 years old and she's typically developing. And for this one, what I want you to look at is how she initiates or begins a conversation. So one of the key hallmarks of behavior we want to see in kids is they can start a conversation. Start saying something and someone will respond. So let's look at her.
Hey, tomato and cinnamon roll.
A cinnamon roll. You know what? I think that might be an onion to go under here. A hot dog? Yummy.
The bun.
The bun.
And another one.
Wow.
We're making our breakfast.
Are we going to have hot dogs for breakfast?
All of these things that I'm getting out.
Oh, okay.
But they're here.
Okay, so with Hannah, you'll notice that she's engaging with mom. She wants to show the hot dog and the cheeseburger, and she's initiating. She's starting that conversation, okay? Here is Ryan.
That's right, it looks just like a bit, but I think it's just the top. Is that the top? Ryan, what else do we have in here? What's this?
This is a cup.
A cup? Oh, you're right. There are cups in there. Oh, there's a plate for you. What is this, Ryan?
A human.
What kind of sandwich? What is that called? You have those at school? Is that hamburger? What is it when you put this on it? And then what do you call it? Are you showing her the bun? Mmm. Does it taste good? Do you want a hot dog?
Okay, so with Ryan, you notice he can respond to questions, right? Mom is asking questions like, what's cheese with the piece of meat mean? It's going to be cheeseburger. He can respond. But rarely do you see him initiating a conversation and saying something about the activity that he's doing. So even when they're verbal, and to some degree he is relatively verbal, they still struggle a little bit with initiating the conversation in the first place. Okay, so we're going to move to restricted area of interest, and I'm going to hopefully get to the right one. There it is. Okay, this is Charles and Jason. So both about a year old, and I want you to focus on the social communication as well as the mannerisms or the behaviors of their hands or their body, okay?
Oh, look, look, look. Oh, wow, here it is. Oh, again, last time.
Did you notice? Wants the balloon again, looks up at the clinician and hands it to her. Without saying words, he's communicating what he wants, right? In fact, the clinician knows exactly what he wants. He wants to blow up the balloon and go down again. Okay, let's look at Jason.
It's getting smaller. Getting smaller. Whoop. Says you tricked me. You took that as a balloon. There's balloon. You give it to Mama? That's excitement. That's his excitement. I see that.
Is it?
Okay, so do you see the repetitive behaviors with the flapping? So that's a very common repetitive behavior we see, including adolescents. So oftentimes it'll be large flaps, like the whole hand flap. Sometimes it's a little hand flap. Sometimes it's even just a finger or a movement like that. Depends on each kid. Each kid might have different ways of expressing their restricted repetitive behaviors. And in this case, Jason was actually expressing something. What do you think he was expressing? He's happy, right? He's excited. He's saying, wow, I like this balloon, and I'm expressing myself through the flapping. And oftentimes that's the case with a lot of these repetitive behaviors. They come out of an expression of excitement or happiness, or sometimes they're overwhelmed. But oftentimes the big flapping behaviors comes from excitement. All right, let's see if I have another video here. Yeah. So in this video, and then I'm going to go back to the PowerPoint. Okay. So this is Will. So Will, I'm going to show you the first video, and he's 1.5 years. And then the second video, he's 3 years old. And he's really focused. His restricted interests are long things. So long sticks, slinkies, anything that's long, and that anything long, actually, in this case. So let's show the first one.
Come on, let's go read a book. Will, you want to come sit in Mama's lap so we can read a book? Will, come sit in Mama's lap. Let's read a book. It's story time. It's story time. Come on, sweetie. Come on, let's tell a story. You want to read a story? Come sit in Mama's lap. Good job. behind. And a comb, and a brush, and a bowl full of mush, and a quiet old lady whispering, hush, hush. You want to try another book? You're very distracted. All right, let's do the train book.
All right, do you notice that he was really interested in this? I think it was like a screwdriver or something that was a toy there. Okay, here's him at the age 3.
With the rocks. Will, do you want more bubbles? Will? Will? Do you want more bubbles? More bubbles? Oh, bubbles! Bubbles! You got a stick?
So, and then he found the stick. So there's a lot of exciting things around him. There's a book, and when he was a year old, there's bubbles, but he's very much focused on the long object. Whatever that long object was, the stick or the screwdriver toy, he wanted that long object. So whichever restricted interest it is for each kid, and each kid might have different interests or different behaviors, generally what we're looking for are these social communication issues, and I'm going to put them out there. We're looking for social communication difficulties or deficits in social interaction. We're interested in whether or not they have restricted or repetitive behaviors, whether it's present early and the cause is clinically significant symptoms, meaning it has to be problematic. We all have our quirks, right? I mean, really, like for those of us who twirl hair, pick our nails, we might not like certain things like nails on chalkboards are very uncomfortable for many of us. The difficulty is, does that impede our ability to be successful in our daily lives? If it is, and that would suggest it's clinically significant. So for Emily, she really had some deficits in social interaction, right? So she was really not looking at her parents' faces. She struggled with engaging with peers and did not play with her peers at all. She also twirled the Lego, right? That's the restricted behaviors. They were started early when she was at least 18 months, and that's when the parents started noticing, but it may have been there prior. And it really made it difficult for her to be successful in school or with her friends. So that generally is kind of the key symptoms of autism. So the question is, why do some children have autism? What are the causes of autism generally? And what we know in terms of just prevalence rates is that 1 in 68 children are identified with autism spectrum disorder. And there's been a substantial increase recently, particularly in the last 10 to 20 years, with the number of children diagnosed with autism. So there's controversy about why this is the case. So some researchers argue, well, it's actually a real increase. Like there might be something in our environment, unidentified. Maybe it's related to food additives or toxins. Other researchers say, well, maybe it's changes in lifestyle. Women aren't becoming pregnant until later in life. Maybe that has something to do with it. Alternatively, other researchers say, well, we know more about autism now. We talk about autism. And so parents and teachers and pediatricians are becoming more aware of those early signs and therefore are more likely to refer. Furthermore, mental health professionals are more likely to say a specific diagnosis so that the child can access special education services, mental health services, and access funds, typically from the federal or state governments, to provide treatment. So the question is this increase substantial? Is this a public health concern? Maybe, maybe not. But what we do know is 1 in 68 children are diagnosed. And it's across racial and ethnic groups. And interestingly, 4.5 times more likely to be a boy than a girl. So overall, there's no single cause of autism. It's really a complex interplay of biological and environmental factors. what we kind of know, and I'm not a geneticist, FYI, but I'm going to try to talk through this a little bit. But what we do know a little bit is that if you look at identical twins, if one child is diagnosed with autism spectrum disorder, the other has a 36 to 95% chance of having autism as well. Now, 36 to 95% is quite a large statistical range, but what that means is that there's a number of research studies finding a high rate of genetic factors in comparison to, say, fraternal twins, which is really 0 to 31% chance for the other twin to also have autism. So there's certainly a genetic factor. We also know that there's certain genetic or chromosomal abnormalities with children with autism, particularly with Fragile X or Down syndrome. So there's higher rates related to that. And although there's no single gene associated with autism, there's some studies that suggest neurexin-1, which is a gene that produces proteins important to the kind of early brain maturation and neural connections, might be associated with that. In fact, what some of the research is showing is that it's almost that the brain is over-efficient, and that for most children, their brain prunes, meaning the neural connections kind of decrease over time and become a little bit more efficient. But for children with autism, it seems that the brain isn't quite doing that. And there's actually differences in head circumference compared to children with autism and children without autism. So there seems to be some brain structural functioning differences between children with autism and children without autism. There's also some early environmental risks that we have some preliminary but not definitive research. Some of the research says that prenatal exposure to some environmental toxins like pesticides or pollutants or viruses might also be a factor in why some children develop autism spectrum disorders. It's preliminary, there's not as much research in that area, but certainly something to be aware of, and the research is kind of moving towards that direction of finding out what environmental as well as genetic causes. Importantly, what we know does not cause autism are vaccines. And what I'm going to present a little bit is why this perception is around and why this is a public health concern. So in 1997, Andrew Wakefield, he was a researcher in the United Kingdom. He published a study, very small case study, without any experimental control, meaning nothing to compare it to. And he suggested that there was a link between the measles, mumps, rubella vaccination, or MMR vaccine, with autism. The problem is, about 12 years later, the editors of that paper realized he falsified the data, completely falsified it. It's not real data, and later retracted the paper. But unfortunately, his research stuck. And what's happened is that members of the public, including celebrities, have really perpetuated this myth that vaccinations cause autism. And we kind of understand why parents might truly believe that. Because if you think about the symptoms of autism that I presented, those are early developmental milestones that they're achieving or not achieving, right about the same time when that first MMR vaccination is given to the child. So what's happening is that parents see the behaviors change right after this major event that happens in their family's life, and certainly that can cause alarm. And I understand that for a lot of parents that can be really problematic. So because these two events are linked together, there's often a misconception that the vaccine caused autism. But within the last 5 years alone, I was looking at the recent research to see if there's something else that came out. I mean, we're talking about meta-analyses of meta-analyses, which are studies of studies of studies, looking at tons of children. In fact, one study in 2014, 1,256,000 children were included in this meta-analysis, and found no relationship, no significant correlation between vaccinations and autism. So that is a positive sign that we know vaccinations are very, very important for our public health. And certainly each parent can make their own decisions about what they want to do with their child. But we do know for sure across the board that the vaccinations don't cause autism. Another perpetuation myth, which I hadn't heard about as much because maybe it's before my time, was this idea that autism and the lack of social interaction was due to a refrigerator mother. So the refrigerator mother was this perceived cold, neglectful mother who then didn't give them the child social interaction and therefore led to some of the symptoms of autism. That was mostly in the 1970s and 60s, and currently we know that's not the case, which is a good thing. Okay. So what do we do? So now that we know some of the symptoms of autism, we know some of the behavioral kind of symptoms and symptomology, there are lots of interventions being developed. And fortunately, there's a lot of interventions that we know are very, very effective. There are some interventions that are little empirical support, meaning these are interventions that have been tried, have been tested in research experimental designs and really shown little empirical support. So as an example, pet therapy is a popular one that we see maybe in our newspaper articles. There's been no research to show that it decreases anxiety in children. But as a lot of you know, pets are an important part of our lives. So that doesn't mean the pet is going to be harmful. It just means it doesn't necessarily address the underlying causes of autism, or underlying symptoms of autism, excuse me. Also, another one is kind of diet therapies or mega vitamins. There has been some research to show that children with autism have some dietary restrictions, like needing to be gluten-free. And that might be the case, and that might be important for gastrointestinal reasons. But currently, there's no interventions to show that those diet therapies necessarily reduce the symptoms of autism. What we do know is that home-based and school-based interventions are really the gold standard. The earlier the intervention, the better, which means the earlier you can find or catch those symptoms, the better it is in terms of long-term prognosis. One of the critical aspects of kind of thinking about home-based and school-based interventions is that it's really important, and as a school psychologist myself, that I feel inclusion in the school environment is the most important aspect of their development, meaning taking a child away from their classroom environment, putting them into a separate room away from their peers, is not necessarily the best way to have them learn some of these social skills. So an inclusion model where their special education needs are provided within a classroom-based setting is more effective in the long term, because guess what? They've got friends to learn from. They've got peer models, right? Early intensive behavioral intervention, or what we call applied behavior analysis, is probably the most researched and shown to be the most effective for most kids with autism. So behavioral therapists focus on a child's overt behavior rather than, say, parent-child attachment. So behavioral therapists, we tend to look at what we see versus what we imagine is going on in terms of relationship. What I can see is a behavior, and I can measure behavior, and therefore I know if the intervention is changing that behavior. So as an example, and I'm going to give a real example, we had a kid who really struggled with starting a conversation. He was 11 years old at the time. And because he struggled with starting a conversation, we had to teach him to start a conversation. So think about, what is a conversation? It requires eye contact, a word, right, to converse. It requires two people, at least. It requires you starting a conversation somehow. So if I just went up to you randomly and it was like in the middle of a conversation, you wouldn't know the context to it. So I have to greet you. I have to say hello. Hey, what's up? Okay? So think about it as just the greeting. So now we have initiating a conversation to greeting. Imagine yourself now having to define to a child what a greeting is. A greeting is when you go up to a person you don't know or you do know and you say something like hi or hey or what's up. But you don't say hey, what's up to a teacher, although unless you know them really well. But you can't say hey, what's up to, let's say, someone at a restaurant that you don't know who's sitting away. It's very specific. It's very, very specific to a particular time. So now I have to define, okay, when it's a child your age, you go up to them, you get, and then not too close, right? This is not good. Hi. This is good. This is not good. This is good. Okay, now you're trying to define, okay, remember, my goal is to teach them how to initiate a conversation. Now I'm going to space. Hey, what's up? Now I'm just looking at you, not blinking, and staring really uncomfortably. I actually have to look away. So when I say, hey, what's up? I say, hey, what's up? And I don't just stare at someone in the eye. That actually makes people uncomfortable. So now I have to define, well, it's not too much eye contact, but you need to look at them, and then look away, and then look at them again. And then you try to really define our social norms, and it's like, whew, mind blown. So now you understand why I'm really interested in culture, because this is what our culture says. Because guess what? If I was in Japan, I don't look at them in the eye if they're an adult. You have to look below, look down. That is polite. And it depends on which person, and it's a mother or father versus a hostess at a restaurant. And all of a sudden you have all these rules, and the kid's looking at you, and they're pretty smart. They'll look at me like, I give up. Like, I don't know what you're talking about. This is too hard. People are too complicated. And I'm like, dude, you're right. Because we are complicated. And when you have to start defining it, it's really, really challenging. And so behavioral interventions are really helpful because now I can focus and say, okay, day one, I'm talking space. Because this dude is coming up to me, he's 12, he's got a little BO, and I'm like, all right, this is what I'm talking about, right? So behavioral therapy is really helpful. And typically behavioral therapy is done with children who don't have any language, as well as children who do have language skills. And I want to show you one example, which is discrete trial training. This is typically done, again, to be very specific on a behavior and to train a particular behavior to occur. So let me get to that video here. Okay, there we go. Okay, so what you're going to look at is she's 2 years old, and I'll explain it after and just kind of take a look at the tree.
Oh, you want beads. Okay, good choice. I like beads. I need to accessorize. Ready? Layla, do this. Yes, that's waving. Good job. Layla, do this. You put your arms up. Good work. Here we go. Oh. They're so pretty. They're so pretty. Ready? Layla. Do this. That's it. You did it. You did it. You did.
Okay. So can you guess, just based, you don't know much about her, but can you guess what her restricted area of interest is? Lisa? Beads. That's her. So we oftentimes use their area of interest as the reward. So if they get the thing that they want by working towards it. So the goal of this behavioral therapy was really just to teach her how to imitate. That's all it is. It's just learning how to imitate another person's behavior. Because by learning how to imitate, well, now you can take the next step and say, well, look at what Bobby is doing. Bobby is smiling. Bobby has his hand up. In school, when you want to talk, you have your hand up. Do what Bobby does. So imitation like this can be really critical in making sure that the child's learning, oh, if I look at someone else and what they're doing, I get rewarded. And discrete trial training is one specific applied behavior analysis method that is quite common, and we take data on it and make sure, that it is actually increasing that behavior. Another method we use is the TEACH model, which is essentially in schools, and we actually use this for typically developing kids too, because we know that they're so effective. How many of you like to write a list? Just like writing a list and being able to check it off. That is just incredibly satisfying. Yeah. I write lists even when I've done the activity just so I could cross it off. It's rewarding, right? So that's what this is about. This is about making lists, using visuals to show our routine. I mean, think about it. Last time, I don't know, I'm a morning person, but I wake up, I go to the gym, I come back, I have my coffee, I have my breakfast. I have exactly the time that I can time from my house to Skaggs Building. I know exactly, and if something happened to get in the way of that, I'd be just flustered, right? So routine is a really natural human experience, and we like it. Children with autism really like their routine. While we might be like, oh, that sucks. I can't believe that, Madison Street Bridge had a traffic thing and I had to wait 5 more minutes while the light changed. Oh, well, I guess I'll try it again tomorrow. For a child with autism who likes that routine and really needs that routine, if that routine is broken, the rest of his day is done. He will let you know, too. He will make your life really, really challenging and cry and yell and hit. I came back from last summer's treatment program with scratches on my arm. I had been spit in my face because they're frustrated and they haven't learned how to express their frustration. And when routines are happening, that can be really helpful in navigating this really weird environment called human beings. And one of the methods is, for example, a picture system like this. So we might say, okay, our morning schedule, we put away the backpack, and then we go to circle time, and then we have math. We like routine, and really this method is integrated across the whole day and has individual visual schedules as well as group visual schedules. At the University of Montana, I mentioned a little bit of some of the treatment programs that we're doing here. One of the ones, so that's Professor Jennifer Schoffen-Clausen. She's in the Department of Community Sciences. She's the pediatric director over at the DeWitt Wright Care Center. And she and I really have kind of started this program. And the cool thing is, my graduate students who are PhD and master's level school psychologists work with her speech and language pathologists pre-service. And so they work together as co-therapists in a broad array of children. So far ranges from 6 to 16 so far. And they really collaborate together. And so from our perspective, and I want to train future school psychologists, I didn't work with a speech and language pathologist until after I graduated from my program. And so this is a pre-service opportunity to get real experiences and really close supervision. In fact, I'm literally next to my students saying, give him a reward, praise him, go. And give that student, that graduate student, an opportunity to practice all these skills that I'm teaching in the classroom environment. And similarly, she does that with a speech and language pathologist. She started the Mosaic program, and so the Mosaic program is for adults with autism. And it's really innovative and really creative. I love what she's doing. I'm less involved with adults. I'm child-focused. But she's doing really cool stuff where they have a peer, a college student, work with an adult with autism who's trying to transition into college life. Okay, so you can imagine what our general cultural environment is like. Add college freshmen to it, okay? And all the nuances of what dating, I had this whole treatment plan once with a 17-year-old to tell him how to flirt. It was so hard. So hard. It's so hard for typically developing people. And I was trying to think, okay, he was asking, he's like, I want to learn how to flirt. There's a really cute girl. How do I flirt? So add college students and the transitions, and there's no one helping you in this big world of college. And she's developed a really cool program with Mosaic. And so her students take a course, so they get credit, and then they help with the treatment plan, walking through how to get to class, how to go use the cafeteria, how to navigate social environments. So I'm pretty impressed with her work. And then, of course, our treatment program is called Youth Engagement Through Intervention. And we started this almost when I first came here, so 6 years ago. And what we started to notice is that the marriage of language and behavior is what defines autism. So my expertise is in really severe disruptive behavior and handling really severe, I mean, I wasn't joking when I got scratches. Like, I help parents and teachers figure out how to handle really disruptive behavior. But when we have a disruptive behavior, it's often to communicate something. It's not just to be manipulative or be mean. It's often to communicate frustration, communicate something you want. And so from Professor Schofer-Clausen's perspective, she's like, well, they're trying to say something. They just don't know how to say it and say it in a healthy way. So we came together and we have youth engagement through intervention. And there is a semester-long 8-session treatment program every semester. Our psychology students, so clinical psychology and school psychology students, work under my supervision over at the Right Care Center. And we also have a summer treatment program. In fact, our next summer treatment program is June 12th. And that's a week-long, all-day, 9 to 3 camp. We call it camp because oftentimes these kids they're unable to be successful in a regular camp. We integrate behavioral therapy and all sorts of different kinds of therapy using evidence-based practices. I won't go into too much detail about each of these, but essentially we use research, empirically supported practices that we know works for kids with autism and integrate it throughout the day camp. So just as an example, another weird social norm that we have is locker rooms. Okay, so think about it. Like, you probably don't think about it because you probably have learned it. So for women, you're allowed to talk while you're peeing. You are. You can be in your stall and you can talk to someone way across it and it's socially okay. Not okay with men. You typically are silent. In fact, it's quite uncomfortable if someone's talking to you. Apparently. This is what my husband tells me mostly. But also think about locker rooms. Okay. When there's a whole series of lockers, so you're going in, and we're going to go take them swimming, which is honestly the best part of their day, is being able to go swim at the Grizz pool. Well, that involves them changing themselves, putting their things in the locker. But when you go to a locker room, and you have a whole row of lockers, if someone's at this locker, you're not supposed to go to the locker next to them. Our social norms say, do a couple over, or all the way across. There's nothing written about this rule. I don't know how we know that this is a rule, but if you break the rule, people are going to look at you. And they're going to be like, really? Seriously, there's a whole thing of lockers down there. You could have moved over. So as someone who's typically developing, I look at them like, oh, I'm sorry. Yep, okay. Let me move my stuff over. If I'm not typically developing and I have social interaction difficulties, I don't notice the facial affect to tell me that this frown and kind of like, that means something. I don't have the ability to determine, oh, that person's uncomfortable. Maybe it's something about me that's making them uncomfortable. Let me move away. So that is one of our lessons. How to choose the locker. That is an entire half hour with role-playing practice. And the kids rock it. They know exactly that rule. And they learn that rule, and they maintain that rule. They also know when someone doesn't kind of follow that rule, and they'll let that person know, right? Because that's the rule. And one of the ways we do this is through social narratives. So it's sometimes called social stories. The social narratives gives us the rule. And what we know is if we are very explicit about the rule, then we can follow the rule. And oftentimes for a lot of these kids, they just haven't learned the rule yet. And so at Yeti, we say, when I eat, I use a napkin. I use the napkin to wipe food from my face and hands. When I finish eating, I use my napkin one last time to be sure my face and hands are clean. I am careful not to wipe my hands and face on my shirt. When I use my napkin, I keep my face and hands clean, and then I don't get other people or toys dirty. Everyone likes it when I use my napkin. So we often integrate these social narratives along with role-playing or video modeling to reinforce that this is a social norm expectation. And we have all sorts of different ones. Our graduate students come up with all sorts of creative ways to teach them things like this. And one of the ways, as just an example of what we do in Yeti, is use video modeling. So this is actually Professor Schofer-Clausen's son. He ends up being our actor all the time, okay? So he's really used to it. But here's an example of what we might do for making plans.
Hello, Caitlin, this is Grady. I was wondering if you want to go to Splash Montana.
Sure, I'd love to.
First, ask your parents. They said yes? Awesome. I'll see you at 3 p.m. on Saturday.
Works for me.
Well, bye, Caitlin.
So with Grady's here, an example, we're using video modeling to show how to plan an activity with a friend. One of the biggest things we do in Yeti is actually learn how to make a phone call. A very, very difficult thing because it takes planning or executive functioning, which involves organization, planning, making sure that things are step by step. It also requires, what if no one answers? And so leaving a voicemail. It also requires saying, hey, let's get together, but we have to ask our parents. So obtaining permission from parents. And then ultimately getting to hang out with a friend. That's a lot of steps all the way through. So this is our first step in trying to teach them how to make a plan with a friend. And the cool thing about Yeti is that oftentimes these kids have never had another individual beyond their sibling playing with them. Because their peers, unfortunately, oftentimes there's a lot of bullying with a lot of the kids we serve. For the higher functioning kids with more verbal skills, they're a little bit more aware. And so their IQ is a little higher, they're more aware of their social environment, but they still struggle with those deficits. So they're very hyper aware when they get rejected. And so the thought of rejection, handling rejection, is actually a core component of Yeti. What to do when someone doesn't want to play with you. And how do you handle it? How do you feel? And teaching them these skills, these rules, these social norms that we take for granted can be really helpful as they navigate this weird environment of our world with human beings who aren't predictable, right? There are people who act in ways that we don't predict. And so we try to give them the tools as much as possible to handle a really challenging environment. So thinking about Emily again as we kind of wrap up today, we have Emily who is struggling. And sometimes when a parent recognizes, oh my gosh, my child has been diagnosed with autism spectrum disorder, that can be very devastating. The way I think about it is there's grief involved with the diagnosis. My narrative, my story of what my child would be in 20 years has now potentially changed. But the cool thing is, we have so many research-based, empirical supported interventions that help kids. They can be successful in school and life. There are a lot of adults with autism who find their niche and they find their success and are totally able to go through life and be happy, be married, have a social relationship. And for someone like Emily, absolutely can be successful. We also have a lot of resources here in Montana. I wanted to share that with you. So I'm involved with the statewide autism project, which we're trying to gather as many stakeholders across the state in sharing early signs of autism. And so I brought lots of handouts that please take with you about developmental milestones. I also work with Marty Blair and Rural Institute, and there's the Montana Autism Center here in the university that I've been working closely with. We also have a number of clinics on campus. The Clinical Psychology Center, which is affiliated with the department I'm in, psychology, we see a lot of kids with autism, and we provide both, typically mostly assessment, but we also provide therapy and interventions as well. And many people don't know about our clinic, but we primarily do a lot of adult therapy. But we actually do a lot of work with kids, and we know that the interventions that our students are going to be doing, because they're graduate clinicians, are going to be the gold standard, right? We know that they're going to be choosing the therapies that are going to most likely work. So, and then finally, the Child Development Center here in Missoula. It's a wonderful organization. They do a lot of work with kids with autism, do a lot of assessments, and provide support for families with kids with autism as well. So on that note, I will say thank you, and I will open it up for questions.
I'll help you spell the question.
Okay.
All right, so questions. We got one right here.
Oh, sure.
Better bring the mic. And we're asking you to use the microphone because this is being recorded for MCAT, and this is why how we'll make sure that the questions are part of the discussion.
One thing you didn't address at all was connection between autism and mentally disabled. But my question really was, how do you train adults to deal with autism kids, teachers, parents, mentors in school, and so forth?
So kind of a two-pronged question. One is that, yes, you're right. Intellectual disability is highly correlated with autism spectrum disorder. So oftentimes, kids with low intellectual functioning might also have autism spectrum disorder. Yeah, absolutely. And the second question was, how do you train teachers and parents? And there's a lot of different ways. I do a full-day, 6-hour workshop. I've driven all the way to Glendive in January. It was very scary. Training, so a total of 400 special education teachers, paraprofessionals, principals, administrators, school psychs, speech paths, in youth engagement through intervention as an example of how to use interdisciplinary professionals within the school to support a child with autism. So that's one way. A common way of providing treatment is to work directly with the parent. So work with the parent in how to reinforce certain behaviors, like imitation, so practice imitation during a regular day. Use rewards. Sometimes it's their area of restricted interest, but sometimes it's food or something else throughout the day. And the Child Development Center, for example, has family support specialists who come in and support a family and learn the different methods and therapies available for kids with autism. And so the parent is learning oftentimes that way too. Of course, there's all sorts of workshops and trainings as well for a variety of different professionals.
Another question.
You're talking about how you're dealing with children now when you have some gold standard treatments. What about the 25-year-old adult now? Are there still things that can be done for those adults to continually increase their ability to function in the world?
Yes, great question. There's absolutely resources. So VOC rehab services oftentimes work with, it depends on before I begin, I think it depends on the level of functioning. So there are adults with autism who can absolutely live independently and successfully and have certain routines and things that they're doing they've learned to be successful independently. There's also group homes so that there is professional support within a group context, and there's kind of semi-independent living. And then sometimes adults are living with their parents because they can't afford to have an individual nurse to support them or individual therapist to support them on a day-to-day basis. So it really depends on their language skills, their intellectual functioning, their overall functioning as to the degree to which they're able to be successful by themselves. There are supports, but less so, which is why, Jennifer Clausen really got Mosaic going because this is one of the few programs in the country that are supporting college-age students with autism who are smart and want to be successful but can't navigate the social environment. So yes and no.
Anisa, thanks for the presentation. It was great. I noticed in your therapy it looks really person-intensive, that to deal with the one child takes the full attentions of an adult who's been properly trained. And so I'm wondering, knowing the incidence of autism in the population, how are we doing in terms of having enough treatment specialists to really take care of the issue? And what are the training needs we have to sort of train enough people to really deal with it?
That's a great question, and something I'm very passionate about. So in Montana, first of all, there's not enough professionals in general who are experts in specifically in autism. One of the things that we're looking for is looking at the paraprofessionals, so at the BA level professionals who are trained in behavioral specific treatments. In fact, in our department, we've been talking about integrating more undergraduate courses for psychology majors, because there is a huge workforce issue in the state of Montana for specifically BA level professionals. They don't need to necessarily have a PhD or even a master's to necessarily learn some of the specific strategies to support both children and adults. And so we've been actually talking a lot about that for the last 6 months to a year, because we're getting feedback from Marty Blair at Rural Institute, really kind of getting pressure to say, well, how can we support a lot of these voc rehab facilities, agencies that need bachelor level professionals. So how do we do it? We have courses. We integrate psychology majors into taking more behavioral focused interventions. We have one course in our Department of Psychology that is taught in the winter only, because there's not enough faculty and enough supports to do it. But it's feasible. It's absolutely feasible. And also, we're talking about working with speech and language pathology, so working with the communicative sciences, working with Anne Garfinkel over at the College of Education. She is well known for her work in autism, and figuring out how we can do the more interdisciplinary coursework, training programs, so that we can really make sure that the workforce is there. I would love to see in 10 years substantial differences in especially really rural communities. There's even one school psychologist for 11 schools. So even among those who are trained in it, there's not enough of us, right? So.
Could you explain how autism is related to Asperger's? Is Asperger's a subcategory, and then what Asperger's is? I hear lots of jokes in the academic world about it being the site of Asperger's.
Yeah.
I'd like to have that explained.
Yeah, thank you for bringing that up. I was debating whether to go into this. So this is a good, okay. So before 2013, the Diagnostic and Statistical Manual, which is our Bible of diagnostic criteria, included autism and included Asperger's, and it also included pervasive developmental disorder. In 2013, the American Psychiatric Association put them together under the category of autism spectrum disorder. People in the Asperger community were very upset by this. So they often call themselves Aspies. There's a Aspie community online. There's social networks. There's people with Asperger's tend to have higher IQs, have really awkward or social engagement deficits, but typically not to the degree of someone with more lower functioning deficits. So there was a community, in fact, there's a social network, a social media group, where they would put up video models for themselves of how to flirt, how to get a date, right? And the Aspies, they call them Aspies, felt very much like this is a community, and I identify myself in this community. So when the American Psychiatric Association removed that, there was a loss in identity among many people with Asperger's. And so oftentimes they'll still consider, still identify with Asperger's syndrome. Currently, if I had a child with high functioning autism, I would say autism spectrum disorder and explain, but I would not, no longer it's considered a category. No, since 2013, yeah.
Hi, thank you for your wonderful presentation. I'm a retired teacher and also the grandmother of a 2-year-old, and there were a case in point there, I guess, where it was Hannah and Ryan. And Hannah was typical, and Ryan was...
had some red flags for autism.
Yes, and she was 4 and he was 3. And to me, that seemed like To me, it would have made more sense to me if he had been 4 and she had been 3.
Sure.
So, you know, that's quite a range of difference in age, I thought, to compare those two.
I agree, right? So, just guessing what you're going is that oftentimes developmental milestones, we kind of know where certain kids are going to reach them. And so when you're comparing a 4-year-old and a 3-year-old or a 5-year-old and a 3-year-old, we certainly can see differences. I think that video was just highlighting some of the specific deficits, but yeah, we definitely wanted to consideration their current developmental level and their age.
Okay, a few more questions. There's one up there.
Thank you for your presentation. How are the public schools responding to the a possibility that children with autism may take a longer time to become independent? And are they lengthening the time that they can be spending in school?
So in some states, children are allowed to stay in school until age 25, which is important for those who need additional time and accommodations, particularly for students with special education services. So they'll take more life skill classes, get some additional supports. I don't see that in Montana as much as other states. However, what I have seen is that our special education services are very strong. And the special education teachers, the school psychologists, speech and language pathologists work together in developing individualized treatment plans or educational plans to support them. But the question is overall what public school can do is, my perspective, and I feel very strongly about this, is that it has to be an inclusive model. That kids with autism, students with autism, should not be separated from their peers and put into a separate school for kids with autism or kids with developmental disabilities. That this inclusion of children with special education within the mainstream school is important for typically developing kids to see diversity and ability, and also for the kids with disabilities to be able to learn all of the skills and work and play together in one school. And I think that's what we do really well in Montana. We value an inclusion model. I'm sure there's schools here and there that are better than others, but what I'm seeing is that we need definitely more special education teachers in the field, more school psychologists, particularly in rural Montana, eastern Montana in particular. But the services that are provided are pretty strong. And it's because I think we care, when we're into this field, we care so deeply about these kids and we want the best. The problem is sometimes the resources aren't there the way that we want them to. So I was kind of mentioning a little bit about paraprofessionals or highly trained therapists within the school. But overall, I think having an inclusion model where kids are interacting on a day-to-day basis with typically developing kids is essential for their development. Hey. Yeah, sure. So, yeah, so this is Doug Doty. He is from the Montana Office of Public Instruction. He and I work closely together.
I'm the autism specialist for the Office of Public Instruction, which means I help every school district in the entire state. So part of your answer of what are we doing to help public schools, in the legislature right now, there's a bill to extend special education services through age 19. Currently it's 18. There's only a few districts that go past age 18. So trying to build an additional year in for some kids. We're also pushing for universal preschool because there's an amazing number of kids who show up at age 5 in the public school district who are autistic and have never been identified, never been seen before. The other thing, just briefly, that we're doing for schools is for the last 5 years, it's been my full-time position to help schools across the state, and we've been able to do a lot. If any school district in Montana, you call me up, we got a consultant that can come in and do it for you. We got training that can be done for you. We have free online autism training. I was just counting today, in the last 5 years, we've had 325 people do 13,000 hours of training in autism. So that's just some of the things that the schools are doing.
I appreciate that, Doug. And Doug does really wonderful work, and he's very supportive of increasing the number of specialists supporting kids with autism. So I'm glad you jumped in. I didn't realize about the recent legislator, so that's good.
Okay, well, I want to thank Anisa. Oh, did you have a question?
Yes, I did have a question. My question is in terms of timeline. How long does it take to diagnose, and how long does it take to have a education geared towards that specific person with their specific diagnosis?
So the question is, how long would it take for me as a psychologist to diagnose? That's a good question. I guess on average, I went from start to finish, it takes me 5 to 6 weeks. So all the testing, interviews with all the relevant, doing observations, full gamut, start to finish, maximum 6 weeks. I mean, I could do it probably quicker if I needed to. But yeah, it doesn't take too long for an assessment. It takes a lot of time, and it's really specialized to do an assessment like this. So that's kind of one of the concerns in terms of lack of resources in our community. There's not enough psychologists. There's not enough those who can do all the testing. But fortunately, our public education system has those resources within the school. And I would encourage anyone, if they're concerned, to approach the school psychologist, approach the speech and language pathologist with the concerns about a child, and they would be able to work with the school system to support that child too.
Anisa Goforth, rock star, showing again.
Thank you. Thank you.